Hello, my name is Hugh and I'm a Practice Development Manager here at the Social Care Institute for Excellence. Welcome to the fifth of 6 webinars that we are putting on as one element of a learning and development programme we're running on behalf of the Better Care Support Team and the Better Care Fund, which in turn is part of their work to develop integrated support across health and social care. Our final webinar, just to mention, on metrics and evaluation is running on the 27th of June, so do please visit the SCIE website to register if you've not already done so. As part of my role here at SCIE, I've helped organise the BCST Learning and Development Programme, which has included national workshops looking at a range of themes, including this crucial question of integrated working. It's also worth noting I have worked in and managed a number of multi-agency workforces. A word on how the session will work. You will see, some of you have already found it, which is great, the chat box in the middle of your screen. I urge you to make full use of that to ask questions, make observations, and so on. Towards the end of the webinar, my colleague Jonathan, who is sitting beside me and taking note of what's raised in the chat box, will ask me these questions and I'll do my best to answer them. There will also be questions that I'll ask you throughout the webinar, which you can answer by way of polls that will appear on screen as if by magic, but actually that's Jonathan again. In a couple of days' time, a recording of this webinar and the slides will be posted on SCIE's website. Now that recording might include the sounds of roadworks going on outside our office in Baker Street. I'm sorry about that. Not much I can do, but hopefully it won't be too intrusive. So for the next 45 minutes to an hour or so then, this is what we're going to look at, okay? We will look at it, what exactly, if one can be exact, that we're talking about here. What do we mean by an integrated workforce? We'll then explore 2 recent and I think important papers on this topic, one from the King's Fund, one from the National Audit Office. And then we're going to take an overview of the presentations on this topic of integrated workforces that were given at 2 recent national workshops we organised for the BCST. Some national work going on by AGK, some work going on in the South East by Hilton Nursing Partnership, and integrated working going on under the banner of Healthier Wigan. Now SCIE's been working in this area for some time, so we will then look at other local examples that we and other agencies such as the Local Government Association have supported, and then finally we'll pull out some of the important lessons that all these local examples teach us. Then it's the question and answer session at the end. I hope that sounds okay. But before we start, and to familiarise yourself with the polling function, here we have, as hopefully you can see, a mouse and some humans. The question I'd like you to answer, which will hopefully now appear on screen, is what is the shared DNA between a human and a mouse? Not expecting you to know, but just take an educated guess, if you like, at the shared DNA between humans and mice. It's relevant, I promise, sort of. Any more guesses? Okay, well you are clearly a highly educated bunch out there, because you are right to go for the high end of the spectrum. The actual answer is 92%. And the relevance, such as it is, of that is that if we are that similar to mice, then just imagine how similar must a health professional working towards a better life and better outcomes for a patient be to a social care professional working towards a better life and better outcomes for the same person. Doing it in an integrated and joined up way should therefore be easy. So, the definition, well, what are we talking about here? What do we mean by integrated workforces? The King's Fund a few years ago did some work on this and counted 175 different definitions of integrated working. You will be happy to know I'm not going to list them, and frankly I can't even begin to imagine what most of those are. The definition that I'm going to posit here, feel free to disagree, is that essentially it is a model of delivery that focuses on collaboration and cooperation within and across organisations, with different professionals having a shared purpose for better outcomes for whoever is being served at the time, as I say. So that's broadly my definition. So it is people working different ways with different people and different professionals working to a common goal. So it could, arguably, for example, be two social workers from neighbouring local authorities working together to smooth a move for a person from a care home in one local authority back home in another local authority. But clearly most of the time we are talking about cross-profession working. It's about coordinated care around the individual, and it's about support that ideally enhances each element of it, so it becomes greater than the sum of its parts without, if we're really clever, without overlapping. Yeah. Now it can be multidisciplinary teams, and we've done work on multidisciplinary teams, and you'll find a really good webinar on multidisciplinary teams on our website already. But integrated working is much broader than that. It can incorporate, I think, much looser, more temporary comings together, maybe around a particular short-lived project, around a particular community, or around an individual person. And I think one interesting notion around an integrated workforce is integration within one woman or one man. You know, if someone develops skills that sort of transcend, you know, cross-professional boundaries, you can have a situation where, you know, a person can, you know, integrate in themselves, if you like. But whatever the definition, I think the most important point is this, that people do expect staff to work closely together in order to serve them better. We know this, we know that's what people want, you know, and it's worth bearing in mind, therefore, why it remains so difficult, given that we do know that. Now, I am not expecting you to be able to read this, but last year SCIE was asked by the Department of Health and Social Care, as it wasn't called then, so perhaps that's a sign of progress, to develop an overarching framework that would help local areas understand what good integration might consist of, with a set of metrics to support the measurement of progress towards it. Okay. I'm glad that it is legible for some people, thank you. So we created this logic model that you can see there to illustrate what good health and social care integration looks like. Now the model depicts visually how a fully integrated system might be structured and how it might function, what interventions and services it might consist of, and the outcomes and benefits it would be expected to produce, especially for people who use services and their carers. So the logic model has four main components, sort of running from left to right. Enablers of integration, the things that, you know, help it happen, the components of integrated care, what sort of things you would expect to see in place in an integrated system, and then crucially the outcomes for people who use services, outcomes for services themselves, the integrated services themselves, and then outcomes for the wider health and social care system. And it's important to kind of note those different angles, because it emphasises, I think, how integration and its effects need to be understood from different perspectives. And then the final column is impacts, the longer term benefits that are slightly more nebulous, more difficult to measure, things like sort of value and sustainability. But what, if this were much bigger, you could see more clearly, was that whatever the definition of an integrated workforce, the logic model illustrates a consensus that questions of workforce are at the heart of this whole business of working more sensibly together. We are not going to provide integrated care without integrated workforces of some sort or another. So another poll over to you. Do you consider yourself to be part of an integrated workforce, be from a health background or a social care background? Now I warn you, I'm not going to have necessarily anything terribly insightful to say about the result, but if we're going to spend some time together, it's nice to have a sense of who we all are. Okay, so that was a surprising finding, that perhaps that people answering yes much more heavily weighted from a social care background. Okay, thank you for that. So yeah, there's an interesting point from a colleague here, Roberta, that yes, we were talking about integrated workforces. I haven't really allowed for that possibility in the question, have I? That's bad of me. Yes, Roberta being from both health and social care. But yes, should have included that. Okay. Going to turn now then to look at two recent reports, as I mentioned, about workforce generally. Now, the first one is very recent and focuses on the adult social care workforce rather than an integrated workforce per se. And it's the National Audit Office Adult Social Care Workforce in England report, which came out earlier this year. I don't know if people have had a chance to read it. Now, I'm looking at it here, even though it is specifically focused on social care workforce, because I suggest that integrated workforces need to be seen in the context of recruitment and retention issues more generally, but perhaps especially in social care, because my suggestion would be that it is harder to look for integrated developments and solutions if you're facing an internal crisis. It's harder to address kind of issues in the wider sector if you're really struggling internally. And I think one of the really interesting aspects of the report, which talks about high vacancy rates generally, is that it highlights high vacancy rates in particular for frontline care workers and registered nurses. And I think that's problematic for today's agenda because these are two key roles in frontline integration. And I think vacancies really matter because they tend to get covered in one of two ways. Either you bring in agency staff, or existing staff are asked to stretch their work and take on different roles and work even harder than they already are. And I think both agency staff and very overstretched staff both may lack either the will or the time or both to go beyond the basics and do the kind of relationship building, the reaching out to partners that good integrated working requires. The report goes on to make interesting points about status. They argue, and I would tend to agree, that for nurses there is more kudos working in the NHS than there is for working in social care, for working in care homes, for example. And I think actually probably all roles in the NHS are seen as higher status than working care settings. And it's an issue that pervades this debate, I think, this notion of disparity of esteem between health and social care as something that makes joint working difficult. And linked to that, I think sometimes you see the health system not always considering social care in its planning. And an illustration of this that the NAO points out is that Health Education England has launched a major consultation about workforce in the future called Facing the Facts and Shaping the Future, in which social care is barely mentioned, and you do still sometimes get this kind of divide at a kind of national level. And the NAO report continues on a similar vein. It talks about the differences in working cultures, different terms and conditions, and professional boundaries as all things that obstruct integrated workforce. But then it goes on to make a very interesting point, I think, that there is no body, there is no single organisation responsible for an integrated workforce. That there is the Department of Health and Social Care, but there is no kind of frontline, kind of sector-led body that looks at integration within the workforce, and there is therefore no national strategy. And the NAO call for a strategy on how health and social care roles can integrate and how pay and conditions can support this. And they recognise, of course, and that the funding pressures sort of underpin this whole discussion, that the funding uncertainty militates against the sort of forward planning that we need. So a couple of people have shared their views on what gets in the way. I'm going to ask you all now again to sort of contribute to this. Which of the NIO concerns do you think is the biggest obstacle to integrated workforces? Is it that question of disparity of esteem between health and social care, the sort of different professional cultures linked to that, the different pay of conditions, or their point about the lack of an integrated strategy? So if you could take a moment to consider that. Okay, so there is quite a clear lead for the lack of an integrated strategy, and I think that I think that's a really important point. I think that the fact that there is, there's an awful lot of work going on to integrate health and social care, but nothing that I can see that focuses specifically on joining the workforces together and tackling some of those pay and condition issues. I think you're right to identify that, as the NAA did, as a serious obstacle to what we're talking about here. Okay, so thank you for that. Now, the other report that that I want to look at is slightly older, but goes right to the heart of this discussion, and it's the King's Fund report from 2016. Supporting integration through new roles and working across boundaries. And it looks in some depth at roles that are springing up. I'm sure you will be familiar with them and working with them. You might even have those roles yourself, the kind of what they're calling here care navigator roles or community facilitator roles, where you have people that work often linked to GP surgeries or particular communities, or working with particular people to kind of help people sort of transcend and cross those health and social care boundaries and work in a very sort of person-centred way with them. Interestingly, because these roles are becoming more common, I think, as a way of kind of trying to untangle this knot, there is little evidence about how effective they are, or how cost effective they are. Now we're going to see over the course of the webinar some examples of those, and some examples that I personally think appear to be working quite well, but the King's Fund point to a lack of kind of concrete evidence, but conclusive evidence is frankly always hard to come by in social care in particular, and that they point to the risks that actually these new job roles don't have the oversight and accountability that the more traditional kind of job roles have, which I think is true, but it seems to me on a personal note poor that we can't devise new oversight structures for these people. It ought to be within our scope to, if we're creating new roles, to create management and accountability structures around them at the same time. And the King's Fund go on to say, and this I suspect should be unsurprising, is that these roles are at their most effective when they are part of a wider integration effort. And I think we'll see, and we'll come back to this when we look at the key themes. Actually, if you just create a new role and put all the burden of integration on people perhaps at quite a junior level, not a lot changes in the kind of wider context, and it does need to be part of a whole system approach with senior manager backing. So by contrast, the King's Fund actually sort of lend their weight to reinforcing and supporting traditional roles, and making more effort to develop trust and respect across traditional boundaries between, for example, social workers and community nurses and so on, with an unerring focus on the individual. And I do think, again, this is a key theme to draw out, that if actually nurses and social workers, for example, do focus on the person and not on who gets paid more or whose pension entitlement is better or whatever, that actually some of the barriers do fall away, and people then can develop the integrated working skills. There will always be boundaries. It doesn't matter how you slice and dice the public sector, voluntary sector, private sector, health and social care workforces. There will always be boundaries, and so I think the King's Fund is right to call for more investment in developing the skills that you need to work across boundaries, because you will always need to do that. But it makes the point, which kind of links to the National Audit Office's point about lack of a national strategy, that actually because we have a national health service, but obviously administered at a local level, and we have local authorities who can jealously guard their kind of independence, that actually the integrated workforces look very different in each local area because of local realities. So it is actually genuinely quite difficult to develop a national picture of the best approaches. Okay. Now, before I go on to some of the presentations that were given at the BCS2 workshops that I mentioned, I want to talk about silo working. I am not, as you'd expect, in this webinar going to mount a defence of silo working, but I think it's interesting that few things are more consistently criticised than silos. I'm doing it here implicitly. In fact, the whole BCF programme is aiming for the end of silos, and every conference that anyone ever goes to in health and social care bemoans silo working. There are endless government programmes and a lot of money expended on breaking down silos, and yet they live on. And I think we need to ask why. In part, it is because they are buttressed by organisational structures which may in themselves not be fit for purpose now, if indeed they ever were, and they are of course buttressed too by inertia, by over-caution, by concerns about professional status and all the things that we know about. But it is worth saying, I think, that they are comfortable, they are familiar. Your fellow professionals get you, they get your frames of reference, they get your moans, they get your jokes. And indeed, a silo might even be a specialism, a centre of excellence that actually you don't want to dilute. So, as I say, this isn't a defence of them, but if we are to break them down, it's not enough just to say we must break down silos, as we've been saying that for 30 odd years, and they're still there. And I think we do need to take a moment to remember why they developed in the first place and what they offer people, because they do offer benefits to people, so that we can try and replicate the good stuff when we create new teams and new ways of working. Okay? But enough on what might look like a defensive silo. I'm now going to turn to some examples of where breaking down those silos seems to be working well in the thematic national workshops that we ran on behalf of the BCST, called each of the national workshops had particular themes, hence the name, and yes, as I say, there were national workshops looking at integrated workforces. So I'm going to start with, we had a really good presentation from people working under the banner of Healthier Wigan. Now, as it says there, Wigan was facing financial and organisational challenges in health and social care. The local authority, and this was back in 2011-12, had a projected overspend of nigh on £7 million and facing inevitably a rising demand for services. They had a very traditional service model. They had, and I'm quoting them here, I'm not traducing them, a lack of leadership and direction. There were accountability issues throughout the service and a risk-averse staff wading through very bureaucratic assessment processes. At the same time, their health services were facing the pressures of a growing and ageing population. I'm sorry that the drilling outside on Baker Street is really kicking off here. I hope it's not too intrusive. There were rising waiting times, and they did some work where it identified that up to 3 million A&E visits could have been better dealt with elsewhere. And so they brought in Nesta, very bright people at Nesta, to do some work around this kind of notion of a creative council, and trying to have different conversations, different use of money, that they were finding that the acute hospitals were sucking in all the money and resources, and that meant there were real shortages of kind of community-based staff like district nurses, consultant geriatricians and so on. And with Nesta, they came up with a whole different way of working, And I have lifted their slide wholesale from this. Again, it's quite small, but with what they base their work around, and you will see this as a common theme, is around GP surgeries, placing them at the heart of the system, and in each GP surgery, placing kind of community link workers, children's workers, mental health support, a whole range of different professionals from health and social care, linking, as you can see in the blue box on the right, to the wider sort of statutory and voluntary systems like the police and housing and safeguarding and so on. And the professionals would have daily huddles, and it's top right, connections and joint care planning through place-based huddles. And I like the Wigan approach. They use the word huddles a lot. It sounded very friendly and amicable. And they've devised a system, therefore, that incorporates a whole range of new roles, and crucially new permissions as well, that permission to kind of work differently. That they have devised and put together an integrated hospital discharge team. They scaled up reablement, but crucially, and I think this is another aspect of integrated working, that they worked in a much more integrated, cooperative fashion with providers of services. So they saved well over £2 million through refashioning and redesigning their supported accommodation around shared models of support and sort of more community connections. They reformed their extra care model as well to deliver a more personalised strengths-based offer, which also secured significant savings. And the whole commissioning approach was kind of shifted to a more asset-based one, focusing more on quality and sustainable care at home. They also had a transformation through technology program, which sounds sort of vaguely Orwellian and sinister, but actually isn't. It was a new care management system and giving 400 frontline workers sort of useful IT devices to take out with them, and that in itself saved nearly £1 million. And as I say, crucially, this notion of a daily huddle to manage complex clients in the community. We also heard at the workshops really interesting work from an organisation called Hilton Nursing Partners, who operate primarily in the southeast, so you may not have heard of them if you're not in that area. That they operate, I mean, that they do a number of things, but that they were particularly talking about their home to decide model. The aim of which is that supporting a person to decide their long-term plans without the sort of pressure and discombobulation of being in hospital. So rather than rushing someone who is medically fit for discharge to decide what, do they go back home or do they go to a care home, the model is that they go back home with intensive support for no more than 2 weeks, up to 24-hour support if that's what's necessary. And the support is nurse-led, but includes social care workers as well, and it includes occupational therapists, personal assistants, as you can see. And another example of an integrated approach was how closely they worked with Kent County Council on this. A good example of bridging the gap between the statutory and the private sector. And so under this home to decide model, they piloted it initially with 5 people, all of whom had been earmarked to go into care homes. They all came home, they all had this intensive support, and all 5 stayed at home. So Kent County Council, along with Hilton Nursing Partners, tried it with 13 more people, again, all of whom stayed at home, having been earmarked as people who perhaps needed residential care. And then 30 people tried this in discharges from Colchester Hospital, so different area, and again, all 30 were able to stay at home. So, I mean, a very effective model and a very good indication of what an integrated team can achieve. And Hilton Nursing Partners were clear that mixed professional model was absolutely key to their success. It's worth noting, actually, given that we've been talking about recruitment and retention, that they do have quite an interesting kind of approach to their workforce. All of them own shares in the company, and they were also quite proud of their family-friendly working patterns, that you had 4 days working quite intensively and then 4 days off, but if you were off, you were off, and there was no sudden calls in to cover a sick colleague or anything, so that people could plan around their families. I just thought that was an interesting approach. Another element of partnership working of it actually was that Hilton Nursing Partners were granted access to NHS Jobs website to advertise, which helped them recruit some really good quality nurses. We've heard other examples in Oxfordshire. They've done similarly kind of joint recruitment campaigns between the statutory and the private sectors, which I think is interesting. And Hilton Nursing Partners also identified that, again, as in Wigan, that working with the wider professional network, housing, benefits and so on, again, a different take on the notion of an integrated workforce. They also reflect quite interestingly that things were desperate. There were massive kind of delayed transfers of care across Kent, and it was that they felt that enabled Kent to try something different. And this is the thing we pick up quite a lot, particularly in these kind of straitened times, that things do have to feel as if they're in a really parlous state before people have the courage, I guess, to take very different steps. So yeah, that was Hilton Nursing Partners. And finally, from the national workshops, we heard from Age UK and their personal independence coordinators. Now, personal independence coordinators fulfil kind of exactly the sort of function that Kins Fund paper was looking at. People who will visit older people in their own homes and provide really individually tailored support. Some of them volunteers, but yeah, they would work with people who have multiple long-term conditions in a really holistic way, helping them navigate their way around medical support, but also kind of non-medical, kind of community-based support as well. And I think the sort of takeaway from that, I think, there are interesting lessons to be learned about how recruiting and matching around an individual breaks down professional boundaries and helps promote this notion of an integrated workforce. That they talked about fishing quite a lot. That if you have an older person who's interested in fishing and you recruit someone primarily for their knowledge of love of fishing, then it doesn't really matter what background they come from. All that matters is that they are a good match for the individual. And I think that is a really important way of developing a different style of workforce. As I mentioned at the beginning, this whole notion of integration is a sort of area that SCIE and many others have been working at for quite a long time, perhaps still because we haven't cracked it yet. So we have come across in our time sort of other good practice examples, which I'd like to share, if that's okay. The first is from Dudley. Now, this is interesting in part because it was evaluated by the strategy unit, so there was quite a lot of research going into the effectiveness of Dudley's approach. So, like many of these multidisciplinary integrated setups, this was based in GP practices. They didn't quite have daily huddles, but they had their weekly meetings to look at kind of complex cases in the community, focusing on people who lacked an up-to-date care plan, and who were at risk of hospital visits, people who were kind of yo-yoing in and out of hospital. And they used a kind of risk stratification approach to identify who was most in need. So they would go assess the needs of patients and develop a care plan as a result. And they term this a team without walls, a team around the person with the patient at the centre. Another strand to Dudley's approach, linking more perhaps to the sort of the PICs that Age UK utilised, was the integrated plus worker. So someone whose role was not just to integrate across health and social care, but to link into the voluntary sector, into the community, into faith groups, into sports clubs and so on, and support social prescribing. So that was the approach that they took, and as I say, the strategy unit looked at this and found, disappointingly perhaps, that there was no discernible reduction in hospital admissions, but what there was that there were shorter stays in hospitals post the approach being developed. Now, as mentioned earlier, conclusive evidence can be hard to come by, and the strategy unit acknowledged that it was hard to kind of prove causation rather than correlation between setting up the multidisciplinary teams and the shorter stays in hospitals. But they felt that because we had, there was a community workforce that knew the person better and had developed their own relationships, that actually that did help in the discharge planning, and potentially was the cause behind the shorter stays. The integrated plus role, they could point to quite considerable savings, using social prescribing and using sort of community connections. That was felt to be a real positive. Some lessons that they drew, some hiccups, that there wasn't a shared understanding of what the teams were trying to achieve in some areas. Some GP kind of integrated teams work better than others. I suspect that will always be the case. Sharing case records needs more thought, and we will sort of touch on that because that remains a headache that I suspect GDPR will do nothing to ease in the short term, at least. And that these multidisciplinary teams were easier to set up and work more smoothly around older people with learning disabilities, and were harder to set up with mental health clients. One piece of work that we were involved in at SCIE was the Sutton Homes of Care Vanguard, which has recently ended. Now, this is a slightly different approach, focused on in-reach to care homes. This was just one strand of work done under the Vanguard project. But under this strand of work, the professionals that you can see on the top bullet point there would come together and work in care homes across Sutton to improve the health and care of residents, so a real preventative focus to it. The care homes at the same time would come together for regular forums to share challenges, share successes, and that did seem to lead to a reduction in accident and emergency admissions, and quite a substantial one, and a reduction in the average length of stay. That they adopted the red bag approach, which is popular in many areas now, of making sure that people go in with a bag of sort of important information, treasure possessions and so on, to aid the link between hospital and home. So that appeared to be quite an effective approach. Oxfordshire put together, this is you can see more about this case study on the local government association website. Oxfordshire put together a scheme designed to reduce hospital admissions and speed hospital discharges. So you'll see that a lot of these schemes have very similar aims, and theirs was a liaison point that GPs and families and care homes and hospitals could all kind of access, with an aim to kind of smooth communication, have a very straightforward escalation process for any concerns that anyone had, and to track patients as they move through the various elements of the health and social care system. But the hub, similar in a way perhaps to the Sutton thing, would have a kind of active in-reach to nursing homes to support them and support patient management. This is there's a list here of kind of the professionals involved, and yeah, each nursing home had a named contact, which seemed to be important in kind of strengthening the links with the hub, that they knew who to make contact with. But they also had breaking the cycle weeks. Now, and when I was researching this, I'll confess I had to, I didn't know what a breaking the cycle week was, but having read a bit more about it, I think it sounds like a really interesting approach. Weeks, essentially, in which staff have explicit permission and encouraged to try new things and experiment with new approaches. And I mean, I would be really interested to hear from any of you who have had some experience of this, because I would really like to hear more about how those work, and because I think that notion of permission to do something different is a really important one, and something that people often lack. So this notion of kind of having explicit experimental weeks, I think, is a very interesting one, as I say. Moving north now, always an excuse to get a picture of Durham Cathedral in. So Durham, similarly, these multi-agency discharge teams, again based in GP practices. Interestingly here, as well as kind of links with pharmacists, which I think is, you know, always an important element that sometimes gets forgotten, the more explicit links in Durham with the voluntary sector, which has, you know, really help, you know, link people and help people maintain in their community. And yeah, Durham's approach was focused around these rapid access clinics, again with an aim to keep people at home, and if people did need admissions, that these were done in a planned way, and the discharges planned for at the earliest possible time as well. Durham, similar as with other areas, invested heavily in reablement, but I want to now focus on that last point, that acceptance of assessments by other professionals and the trusted assessor model, which I want to look at now, because I think this is an important way forward, but doesn't always work quite as well as it should as part of the whole kind of picture of integrated workforces. So thanks to NHS Improvement for this, because this is based on some work that they did on what a good trusted assessor model looks like. Just to note that it is legal if done properly. The Care Act and other legislation positively supports the model. Chapter 6.3 of the statutory guidance, if you want support for the trusted assessor model. But be clear about the parameters at the outset, possibly start with a restricted group and expand over time. For example, begin with reablement and move on to residential care, or, you know, roll it out ward by ward across a hospital. But keep it simple, make sure that there's a feedback loop. So, you know, if, for example, a domiciliary care agency accepts a patient based on a trusted assessor assessment and then finds they cannot meet the need, then, you know, people need to learn from what's happened. It shouldn't necessarily be seen as a failure, but it should be seen as a learning opportunity. As we're going back to a point that the King's Fund made, that a trusted assessor model on its own can be beneficial, but it will be more beneficial if it's part of a wider integration agenda. Don't assume the assessors must come from a certain staff group. It could be, you know, ward staff, therapists, social workers, whoever. But just be clear about who is being assessed and what's being assessed. Know the parameters, because again, the term trusted assessor can be used to refer to kind of various different things, I think. So, what do all these different examples teach us? I think first off, it's about relationships, and therefore it's about trust. And we can set up systems that make it more or less likely that people will work cooperatively, and obviously a shared budget, I think, is probably crucial to integrated working, but probably nothing is more important than a sense of trust between the various parties involved. I saw Richard Humphreys of the King's Fund give a presentation recently, and he used a lovely phrase that progress happens at the speed of trust, and I think that's right. You know, if you're going to set up a joint budget, you need to trust the people you're setting up a joint budget with. So whether it's at senior level or frontline staff, you absolutely need to have that trust, and crucially, the patients, the service users, need to have a trust in the integrated workforce as well. Starting small can be helpful. We saw that Hilton Nursing Partners started with a pilot of 5 people. Wigan started their Healthier Wigan partnership in one area of the town. That allows for a greater flexibility and adaptability. And it also, crucially, I think, that willingness to fail. I read a tweet this morning that said, if you can't remember the last time you failed, then you're not taking enough risks. And I think that's probably right. And you know, this is where senior manager backing is really important. You know, that you don't get sacked the moment you try something that doesn't work. We've mentioned this kind of notion of recruiting based on the community or based on the person. AGK was a good example of that. It does lead to a more personalised response. And another key thing that we've seen is how motivated staff are to work in person-centred, community-based ways, that they want to do this. And with permission and support, that kind of message about senior management support again, and systems that don't actively get in the way, staff will work together. But actively work on it, actively support them to do this, have shared away days, have shared learning and development sessions, and role model it at a senior level. I think shared attitudes to risk are really important, because I think health and social care do see different things as risky and see some things as riskier than others. Information governance can feel like a barrier, and there's a really good presentation, there's a really good webinar on our website that we did a couple of days ago about how information governance needs to be involved early, so it becomes an enabler, and not, everything doesn't just break down on the kind of rocks of GDPR and patient confidentiality and so on. The information does need to be shared. Measuring outcomes rather than activity is important, because that's what matters to the individual. And I mentioned senior leadership backing, but also we've heard of places where actually what was felt to be crucial was union backing, that this does require people to work in different ways, and if the unions are supportive of that, and they typically are if they're involved early enough, then that can be that can be real help in avoiding an unnecessary obstacle. Co-location is obviously important, as Wigan described it, sharing the oxygen and the milk. I would suggest it's not enough. You can co-locate people, and they're still working to different systems and under different management structures, and it can it can not work. But it is, so it's necessary but not sufficient to this working. A lot of the examples we've heard of are based in GP surgeries, and that is no coincidence. The GP surgeries are, there is a universality to them. They are the one non-stigmatising entry point into the whole health and social care system. So I think it's right that a lot of these teams are based there. We heard about Hilton Nursing Partnership and Kent County Council changing because they had to change. Austerity means that it can lead towards to drawbridge raising and protecting one organisation's budget, but it does create scope to try radically different things. There comes a point when just doing a bit less of what you've always done is not enough. Data is vital to get permission. If you can prove that this improves patient outcomes, if it lowers costs, that is vital. And there was a lovely phrase that we heard in one of the workshops, that everyone thinks it's someone else who needs to change. So yeah, what I would urge you to be is to be the person that leads on this, to take a lead on this. Effective integration of workforces depends on good relationships, on being willing to try new things, confident in the backing of one's managers, and knowing how to evidence whether the new approach has worked. But most of all, it depends on listening and responding to the desired outcomes of people using services. And we know that that is efficient and compassionate care as close to home as possible. So whatever you can do to that aim, I would urge you to go and do. Okay? So, if you've got any questions, I will do my best to answer them. I don't know whether there have already been some, because I haven't been looking, but I'm getting a shake of the head from Jonathan. So I'm going to pause for a bit, have a glass of water, and yeah, if you've got any questions, do let me know, but I'm conscious we're quite near the end of time anyway. Thanks, folks, for the questions and the observations. I think that is a really interesting point, and it would be great if, I don't know whether that's being trialled elsewhere. It would be great if someone could chip in and say if they do know. Nick, I'm not a commissioner. I know we have stuff on our website about integrated commissioning. I think clearly health and wellbeing boards would seem to be a place to focus those discussions, and Section 75 kind of pool budgets would seem to be crucial. I'd love to see the end of continuing healthcare, but that's a whole separate discussion. Particularly successful in rural locations, Rachel. Does Oxfordshire count as rural locations? I had a rural picture. That's not enough, I accept. I think there are particular challenges, but I think given some of the challenges about rural care, about the distances that people need to travel, I don't know. I think it becomes almost more vital there, where if someone is going out and they've got to drive 45 minutes to get there, it's important that that person feels able to do a range of tasks that person needs. So no, it's a good point. I've spent my working life in London though, so I can't claim first-hand experience of that. Oliver, I'm reading your point. I'll confess ignorance as to what Care Pulse is. Is it? I presume from the description that it's a sort of centralised information system. And I think in London, going back to territory where I did feel more familiar, the fact that you've got 33 local authorities in such close proximity makes that kind of sharing of information across boundaries really important. And absolutely, the concept of integration in training and education is so vital. We did work here a while back on trying to integrate adult mental health and child protection services to support families better where where parents of children had significant mental health problems. And one of the big stumbling blocks that we kept coming across was that kind of division between that specialisation within training and education that meant that people didn't feel comfortable. Adult workers saying, I don't know how to talk to children because I didn't do the child module when I was training to be a nurse or a social worker or whatever. Even people who had children of their own, they still say, professionally they were very twitchy. So I think the lack of integration in training and education is an issue. And I have I've managed learning disability teams, and have managed a couple of people that came through kind of learning disability, social work and nursing courses, and yeah, it did make a difference. It meant that we were employing them as social workers, but that they could speak the language of nurses in a way that most of their colleagues couldn't. Rachel Moring, I don't know if we can find something, but I'd be happy to look and email you, but GDPR wise I would need your permission to email you, because you didn't, that's not what you implicitly gave permission for when you signed up to the webinar. But I might not be able to find anything anyway, but I'd be happy to have a look if you were interested. Okay, Ollie, thank you for that. Yeah, that's really helpful. We are coming to the end, so we just have a couple more polls for you to answer, if you would. Yeah, just curious, what's next for you? Do you get a lunch break now, or is it straight back to work? Oh, I'm glad someone's having lunch. You're a far too hard-working bunch. That is the state of play in health and social care at the moment, I'm afraid. Okay, so and finally, we would just be interested to know whether this has been a helpful session. You can find information about all our integrated, all our materials on integration at the website address, which hopefully you can see. But yes, if you could kindly take a moment just to kind of let us know whether that's been a useful hour of your time. And I will sign off now and just thank you very much for your engagement, for the questions, for the participation. That's been really, I've enjoyed it. I hope it's been good for you too. Thank you very much.